All right. Good afternoon, everybody. My name is Kevin Hsueh. I'm one of the associate professors of medicine in the Division of Infectious Disease at Washington University School of Medicine. We are going to give people 2 minutes to get onto the call, and then we'll get started. I'm glad everybody could take time off on their lunch break to just attend this reintroduction webinar, and glad to see you back. Hopefully, this is going to be the start of something great. All right, it's 2 minutes after. Let's get started. Um, as I said, I'm Kevin Hsueh. I'm one of the infectious disease docs at Washington University School of Medicine. I'm the medical director of the BJH Antimicrobial Stewardship Program, but more importantly for this, I'm the program lead for the Missouri Antimicrobial Stewardship Educational Collaborative. With me is Erin Rackmeal. Erin, do you want to introduce yourself?
Sure. Hi, everybody. My name's Erin Rashmiel, and I am the antimicrobial stewardship pharmacist working with the MASEC group. I did a residency at Barnes Jewish Hospital in St. Louis, and after that, I spent about 10 years working at a rural hospital in Massachusetts, where I started an antimicrobial stewardship program out there and sort of became super interested in this topic.
So today we're going to be talking about what the heck MASEC is. Come on. Who we are, what the program goals of this are, what is going to be happening in terms of education, resources that we have available, training that we have available. Discussing some recent advents in antimicrobial stewardship regulations since the last time. At least that we had this seminar, it was 2019, and certain things have developed since then. And then some open discussion, because what we really want to know is how we can help the people on this call. And I'm really appreciative that so many people have been able to take time out of their day to come listen and hopefully learn about what we can offer. A disclosure, we're supported by the Missouri Department of Health and Senior Services, the HAI-AR program, with support from the Centers of Disease Control and Prevention. I am a hospital antimicrobial steward, and I do occasionally get Medicaid or medical care, so I do actually very much care how people are using antimicrobials. It's going to be a bit of an interactive session, mostly through the ways that everybody is now used to. So if you have thoughts or questions, you can put them in the Zoom chat, or you could just put up your hand and we'll try to answer things as soon as possible. In future lectures, we do have a Poll Everywhere site, pollev.com/MASEC, which will be used for more advanced feedback. Some of you may already be experienced with this. We use that pretty aggressively the last time around. So first, I want to introduce what MASEC is, what the Missouri Antimicrobial Stewardship Educational Collaborative is. This is a statewide educational effort that is sponsored by the Missouri Department of Health and Senior Services. It's been going on since around 2018 intermittently. It was on hold since the middle of around 2019. And then COVID kind of threw that for a loop because people had a lot other stuff to deal with. But what it really is about sharing and disseminating best practices in antimicrobial stewardship. So the DHSS has tapped us, Washington University School of Medicine Infectious Disease Division, to help distribute antimicrobial stewardship expertise, best practices, advice throughout the state, especially given that Missouri is one of the few states that actually has an antimicrobial stewardship requirement built into law. So there are a lot of people working on MASEC. There's a core working group, which you're primarily going to be seeing on these calls. So that's myself. I work at in the ID division at Washington University School of Medicine. There's Aaron. You may also be getting emails from Tracy Habrock-Bach, who is one of our project coordinators. But there are many other team members in the background that we sort of utilize for their advice and for various projects, and that we can tap if anybody has questions. So Dr. Mike Durkin is one of our outpatient antimicrobial use experts. Dr. Sena Sayud is an expert in electronic decision support. Dr. Michael Hendricks is an expert in community hospital stewardship. He covers 3 hospitals at this point, 3 smaller community hospitals. Dr. Mary Politi is an expert in implementation science, how to get this stuff actually done. And we have a biostatistician on our team as well, Alice Bewley. So as I said, the goals of MASEC are to distribute stewardship expertise throughout the state, and also provide a convenient sort of contact point for anybody with questions or concerns or needing assistance with their stewardship program. We are in active, pretty aggressive contact with the Missouri Department of Health and Senior Services, some of whom are on this call right now. So if you have any questions, you can always ping them or leave a message in chat. But one of the things we're trying to help them with, sort of as an addition to this project, is identify where the state can provide more focused assistance with antimicrobial stewardship. So right now, the MASEC program as it stands is composed of 4 different parts. One of which is probably the one you're on right now, which are webinars that we'll be holding periodically, but also an intervention training tutorial, an email consultation resource, and education and reference materials that we'll be developing for the state and hopefully getting posted for broader use. So let me just walk through a bit of each one of these and describe what they are in detail. There are some that are markedly new, so I'm sure people have some questions about that. So the webinars are going to be happening every 2 or 3 months. You'll get invites just like you did today with an email with the appointment time and date. There may be hopefully more people involved in future emails. There are between 30 minutes to 1 hour long seminars. They are focused generally on a specific topic of concern or interest, but can be more broad ranging as well. So things that we've done in the past is talk about regulatory advents and issues, new antimicrobials, new advents in antimicrobial stewardship, new advents in diagnostic stewardship, which is part of the cutting edge of antimicrobial stewardship at the moment. And we've also had clinical case conferences, basically just discussing common issues that we run into as antimicrobial stewards every day, to basically just share how everybody sort of does this. If you have any suggestions about topics you are interested in, you can just put them in the chat right now if you want. But you can also email our common email, which is mostewardship@wustl.edu, to provide any feedback, recommendations, requests that you want. The goal is to have you only have to remember 1 email. So that's the goal. The clinical case conferences generally go with us discussing a case, generally drawn from real life that we've encountered, and then identifying the various antimicrobial relevant issues that have been brought up or were brought up when we saw these patients in real life. So I'll give you an example. This is a 83-year-old woman with Parkinson's disease who's admitted to the hospital. She's got hypertension and is on beta blockers, a history of vaginal prolapse and recurrent urinary tract infections and schizophrenia. She presented to the hospital for new confusion and was found to be afebrile, but with a very high white count of 14.2, a slightly elevated creatinine of 1.1, a pulse of 70, a blood pressure of 110 or 100 over 60, and a respiratory rate of 22, with a positive Luke est with nitrites and a culture pending, and a chest X-ray showing bibasilar haziness, with a UA showing too many to count white blood cells, and who was started on IV ciprofloxacin at 400 milligrams Q12 empirically. So usually what we would be doing is asking people what they see as the issues, but in this case, this is just an example. So things that we have pointed out is that Cipro is not really a good empiric choice for a urinary tract infection anymore, even in the state of Missouri. E. coli sensitivity is generally less than 80%, even for wild type infections. And likely lower in a person with multiple previous UTIs who maybe has been exposed to, say, Cipro or Bactrim extensively in the past. They're no longer really recommended as first-line agents for urinary tract infections. They have a lot of adverse events, or adverse drug effects. So the sort of weight of opinion is leaning further and further away from them as time goes on. Agent pharmacology, so the GFR of elderly patients can be deceptively low. She was an 83-year-old, and a creatinine may be also falsely low if they have unstable renal function. And so that may not be the ideal agent to use if you're trying to dose adjust. You may be overdosing them. In terms of things that should be reminded to the physician, it's that this person may have sepsis. They technically meet the criteria with the elevated white count and the respiratory rate. The pulse may be falsely low because they're on beta blockers, so they may meet more of the criterion than normal. And because of that, what may have been chosen is an insufficiently broad regimen. In terms of how long and de-escalation, actually, this person probably needs to be escalated in terms of therapy because acute broad spectrum empiric treatment of infections is very important for patients who may be septic, especially fragile patients like this 80-some-odd-year-old. And then sepsis and discussing sort of the systemic issue of this being a possible sepsis syndrome, which is difficult to identify and is, at least my hospital is dealing with it, trying to create a more rigorous detection process, and some hospitals have developed screening programs in the ED or surveillance processes. So these are the kind of cases that if people are interested, we can continue to bring up. Just tell me if you're interested in case reviews or you want just topical discussions instead. So one of the new things that we're bringing up this year is a stewardship intervention training program. So I am not sure actually of the demographics of this group, but from what we've sort of encountered, many hospitals, both webinars and topicals, so that we can do both. It's up to, so it sounds like you'd like a combination of sort of topical webinars and case conferences. That's fine with us. One of the things about Missouri is because of the legislation, there are a lot of new antimicrobial stewardship programs. And what we've encountered, even in a relatively urban area, is that many of the hospitals have relatively new antimicrobial stewards. And what we are hoping to carry out this year is a voluntary one-on-one or small group tutorial aimed at walking new stewards through the design and implementation of stewardship interventions. The audience is programs attempting to start or expand stewardship intervention activities, Our goal is to have about monthly meetings for around the next 6 months, starting in early 2024. We would be helping identify the resources that programs have, discussing the barriers that people have in terms of implementation and evaluation, helping with decision making, so helping them identify what are good priorities in terms of which interventions to sort of go forwards with, and troubleshooting when they try to implement something and run into problems, which all of us do. If you're interested, you can put a message in the meeting chat, but you can also send an email to Mo Stewardship if you're just saying, I'm interested in the intervention training program or intervention tutorial. We'll be sending out an invite for interested participants in January, but this will help us really by just letting us know how many people are interested in this type of assistance. Does anybody have any questions about this one? This is new, so this is not like something that we've had in 2018, 2019. All right, going on is our flagship email consultation resource. So using that one unified email contact process, we request that anybody with questions, comments, anything, send an email to mostewardship@wustl.edu. The goal is to have this be a freely accessible resource for stewards throughout the state or people who are just involved in antimicrobial use to ask questions about antimicrobial stewardship. It's available, well, you can email at any time, but expect responses between 9 a.m. and 4 p.m. normal business days. This is not a clinical consultation service. If you do want something like that, I can point you to something, but this is not really meant for that. This is meant for generalized questions about antimicrobial issues, primarily in the hospital setting, but in any other setting, it is perfectly fine as well. So issues that we've sort of discussed with people before, and I expect to hear about in the future, are the excessive use of antibiotics for asymptomatic bacteria, high utilization of fluoroquinolones at various facilities, abnormally elevated usage of MRSA and resistant gram-negative antibacterials for community-acquired pneumonia. I know a lot of hospitals who vancomycin and cefepime are like they're starting treatment for severe community-acquired pneumonia, which is definitely not necessarily appropriate. Questions about personnel support for stewardship programs. We may not be able to solve them for you, but we can definitely help sort of provide context for what other hospitals are doing. And then questions regarding the new regulations and guidances regarding antimicrobial stewardship. So we really encourage just sending us messages. We're here to help. And then we also provide stewardship education and reference materials. So we are currently in the process of building a website for the MASEC program. It currently can be requested at mostewardship@wustl.edu, of course. There's also some that are still on the Missouri State Department of Health website. Currently available topics are like, what is stewardship, what to do about double coverage, what to do about skin and soft tissue infections, and we're planning several more. If you have anything that that we could assist with, where you need some additional education or reference material, please feel free to tell us, so that we can focus on that. So one thing I did want to discuss are recent antimicrobial stewardship regulatory and guidance changes, because I think this really helps sort of frame what is happening with regards to stewardship and why sort of education and continuing developments need to be sort of monitored. So for us in Missouri, this all started in 2016. Well, it didn't start exactly then, but this major effort for stewardship started in 2016 when Missouri enacted legislation which required hospitals and ambulatory surgical centers to have antimicrobial stewardship programs. After that, things just kept, rolling over. Additional requirements started rolling in. So the Joint Commission implemented a medication management standard related to antimicrobial stewardship in 2017. CMS added a condition of participation in 2019. So this means that technically, if you take Medicare and Medicaid patients, you must have an antimicrobial stewardship program. Otherwise, you are violating those conditions of participation. CDC updated some guidance in terms of what is an appropriate antimicrobial stewardship program in 2019. NCQA, which is the sort of other very large accreditation body, other than the Joint Commission, added 3 measures in terms of its HEDIS measures that revolve around antimicrobial utilization and antimicrobial appropriateness tracking, especially for respiratory conditions. So things like pharyngitis. And then more recently, in 2023, the Joint Commission made those medication management standards related to antimicrobial stewardship even more strict, requiring very specific activities. And then the Centers for Medicare and Medicaid added reporting of antimicrobial use and antimicrobial resistance to the CDC's NHSN tracking program as a requirement for their promoting interoperability program. This is what used to be called their meaningful use program, which means that if you, even more importantly, if you want to get proper reimbursements from CMS, you need to be submitting data to NHSN through this module. So if this starts in 2024, so if anybody has not done that, or their hospitals are not reporting antimicrobial use and antimicrobial resistance through there by now, they may want to get started on that as soon as possible. So notable impact of these changes, just sort of in summary, is that NHSN antimicrobial use and resistance monitoring submission is really strongly emphasized both by Missouri State at this point and the Centers for Medicare and Medicaid. So AU is required by Missouri law and CMS, and AR is required by CMS starting 2024. In terms of stewardship activities, well, TJC or the Joint Commission requires that stewardship programs at least be doing pre-authorization of select antimicrobials. So that means you have to sort of restrict certain antibiotics, and that you're doing some kind of prospective audit and feedback on antimicrobial usage. It specifically calls out positive blood cultures, but as far as we know, that's just a suggestion. And that you have to have a process to recommend guidance, facility guidance on antimicrobial usage for common conditions like pneumonia or urinary tract infections, skin and soft tissue infections. And you have to measure adherence, which is a complicated thing even larger hospitals are having problems with. And if people have questions on how people have been doing that, we can discuss that more. NCQA has really focused on specific tracking measures for things like upper respiratory infections and acute bronchitis. Basically, you shouldn't be using antibiotics as much as possible for these diagnoses. And CMS is requiring long-term monitoring of antimicrobial usage and antimicrobial interventions for all hospitals. So now I'm going to open it up to just discussion. We have around 13 participants on the call today, so this is not by any means an unwieldy group. What are people interested in, or what are people hoping to see from this program, or are having problems with in their programs? The floor is open for anybody to raise their hands, or just turn on their mic and talk, or just put something in meeting chat.
Hey, Kevin, this is Brad Nichols at Bothell Regional Health Center.
Hey,
I'm really happy that you guys are back. I really enjoyed it the first time. Got a lot of information from you before. Uh,
sure.
the thing that just jumped out right when you said that is we have a lot of new emergency room physicians, a lot of new hospitalists, a lot of new residents, and they think that cefepime and vancomycin is just the way to go. And we fight them all the time about it. And, we try, and if there's no growth after 48 hours, we try and de-escalate. But
Yeah.
um, yes, just some guidance on that to try and get some of our newer providers, some information, because we know about the whole vancomycin and Zosyn, as far as possible AKI. So any pointers that we could move forward on with that?
Yeah. So, I mean, there's a lot of both guidance and additional information. So, right, vancomycin or vancomycin are really broad spectrum, but they actually, hopefully, they're adding atypical coverage to their regimens. That's actually one of the things we run into in the sort of larger hospital EDs is, they're so worried about resistant gram negatives that they forget about the atypical coverage. That's probably more common for things like pneumonia. So there are different ways to approach it. One is easiest is just general guidelines for um, like a treatment algorithm. We've had a reasonable amount of success in this, basically saying you can start these agents, but these are the appropriate groups to start them in. So like people who are, truly septic or truly have severe pneumonia versus not, and then give them a sort of algorithm for de-escalation. So, first 24, 48 hours, totally fine. But if they're stable, you should de-escalate to, ceftriaxone and azithro or even oral antibiotics, providing them with a rationale to not start broad spectrum gram negatives, and or MRSA agents is also helpful. So I tend to encourage them to basically tell them that if they start broad spectrum gram negatives, it's a lot harder to de-escalate, to switch to something oral, right? There are very few anti-pseudomonal oral agents. Only one really is levofloxacin for, say, community-acquired pneumonia. And so trying to get them to understand that we're trying to help them get the patient turned around and out of the hospital, as opposed to just trying to restrict their antimicrobial usage, has been very helpful to us. When you say the cultures are negative, I'm assuming sputum cultures, or is it MRSA NAIRS?
Well, what we do, we've kind of looked into the mercenaries also, and we've been doing that more and more. So that's been helpful. Blood cultures, sputum cultures. I mean, really, how impactful are sputum cultures, anymore? You usually get a spit culture.
Yeah.
So
I don't know why that seems to be so much harder now.
yeah, I don't know either. But we do, if we don't get any growth from, or it's a negative, if it's a negative swab, we're introducing that it's like, within 48 hours, if it's negative, then we're stopping the vancomycin. That's kind of what our
Yeah.
PAT has done. But still, so we'd like to just keep them on it for a little bit longer. So anyway, we're just trying to work through it.
Yeah, you're bringing up a really important point, which is de-escalation and how to encourage it and how to sort of guide it so that it's done routinely and seen less as like antimicrobial stewardship, trying to be stingy with antibiotics, and more about, this is a standard process. When do you guys recommend to start antibiotic review for de-escalation? We are currently reviewing at 48 hours, but debating to moving out to 72 to longer, having culture sensitivity data. Matthew, so we actually really are recommending review at 48 hours. I mean, it depends on the agent. It depends on the condition, right? For CAP, 48 hours, totally fine. It depends on your lab. So you may want to talk with your microbiology lab if you have an in-house microbiology lab. Ours says that really the vast majority, it's something like 90+% of culture results in terms of just having notification that an organism exists, are positive within 48 hours for things like pneumonia or blood cultures. It's very rare to actually have things sitting out there that are just not going to grow for a while, because most of those are not aggressive invasive organisms. So we've been trying to keep the time horizon short more than anything else, because just pushing it out makes everybody, I think, allows people to feel like that is more reasonable. Like keeping people on broad spectrum antimicrobials for 3 days is more reasonable, when if they're actually stabilized, that's actually, you don't need to do that. The vast majority of our de-escalation is empiric, because we don't have culture or sensitivity data. We have a diagnosis or general diagnosis, like community-acquired pneumonia, like skin and soft tissue infection, and we've been really trying to make it pretty sort of prescriptive. Okay, if you have somebody with CAP, we get organ accession but not susceptibility within 48 hours. So do you guys have an antibiogram or antibiograms? Because then you could use the antibiogram to help guide whether or not you can immediately de-escalate, if it's, say, something that is more commonly sensitive, versus something that you may need to wait for a while. That's more hospital specific. So like if you say get, I'm just gonna throw something out there, E. coli in a community acquired urinary tract infection, you probably can de-escalate immediately. Most of the time, the susceptibility is really not required, because it will be always susceptible to very similar things. Meanwhile, if you get like an Acinetobacter, yeah, you're probably going to want to wait for another 48 hours. But yeah, I can see it. I'm not sure if that's something where you can create a protocol, but especially for empiric de-escalation, we really try to encourage 48 hours, or earlier, even if the person's stable. Because if they're just waiting, another 24 hours is generally not going to make a difference there. But it sounds like what I'm hearing is de-escalation and encouraging it, and what kind of protocols people use are something of pretty significant interest. And so that I'm writing that down is something we should definitely do in our next seminar, both cases and yes, it's a battle with doctors. And that's why one of the things that we've been really trying to do is make it routine, and make it routine to de-escalate without that kind of information, because it can be falsely delaying, is sort of the way that I describe it. And if once they sort of get in the pattern of needing the sensitivity information to de-escalate, then you're always stuck with that. And it slows everything down. It's unnecessary generally, especially if patients are stable. Yeah, Matthew, it's not an easy thing. That's the strategy we've been trying to, and getting some success with, work on recently, because honestly, like 70% of the time they weren't doing anything with the sensitivity information. Yeah, but we'll bring this up in a more formalized fashion, and probably, and it sounds like we need to create some assistive documentation to help with that, and so we can definitely work on that. Any other things that people are interested in? Anyone approach? Oh, sure.
I was just going to say, Kevin, there was a direct message in there. I don't know if you saw it, about minimizing vancomycin use for all cellulitis.
Oh, yes. We have gotten really good with that. Why can't I see that?
Oh, you don't? Oh, you know what? Might have been a direct message to me. So the statement was they are asking for guidance on how to minimize vancomycin use for all the cellulitis patients admitted, because it's being overused in their facility.
We can definitely help with that. We have also been dealing with that. In particular, the use of Vanco, and not oral anti-MRSA agents. We've been really pushing them to not start anti-MRSA agents in general without a purulent cellulitis. But we've gotten a pretty, I think, rigorous like treatment algorithm for skin and soft tissues, tissue infections that we can help sort of distribute. And what we've been really trying to work on is pushing people to use oral anti-MRSA agents if they really need to, like if they're really, for some reason, concerned about MRSA, as opposed to starting Vanco. Yeah, not a problem. I'm writing this down. These are great ideas, because then it helps with conversion, it helps with discharge, and quite honestly, there are very few times where Vanco is really required. So yeah, agree, that's a huge problem though. Like to see something about C. diff in regards to treatment with Vanco. Oh, in a real world scenario. I mean, I don't know if I can really talk too much about a real world scenario, but yeah, there is a huge amount of information about fidaxomicin, and so we can talk about this. The guidelines are still soft on this prioritization of fidaxomicin, but I agree, they seem to be sort of more and more emphatic on it. In specific, what are sort of, I'm assuming what you're talking about is the sort of just the difficulty with payment, and the huge cost of fidaxomicin versus Vanco. Ooh. Did he drop off accident? Thanks,
No,
Matthew.
no, Kevin, I didn't drop off. It's just that you know, a lot of things, you know, how often are they reoccurred? You know, when do we put the, you know, tox? We've got people that come in, oh, they came from the nursing home. Let's go and put them on fidaxomicin. Well, let's try Vanc the first time. Let's see how things go. And you know, it's kind of back and forth. I've read the guidelines. I think they are kind of soft because there's not a lot of data that comes out and said, you know, is the cost justifiable based off the treatment? Yeah, we talk about reoccurrences, and there's sheer reoccurrence with fidaxomicin, but the price disparity is so huge for small hospitals, when we get X amount of dollars, isn't warranted in all these patients.
Yeah, I mean, I think the problem is they have done cost analyses, and it is not cost neutral. It's minor cost. It's a minor additional cost, but the problem is that they don't take into account the fact that our medical systems break costs into different silos, and when the cost is all being incurred by the hospital, that makes it unsustainable, even if, you know, total lifetime medical costs for that patient may be neutral to slightly increased, right? So,
Right.
So it is a huge problem. So we have switched. So Barnes, the tertiary care hospital, has switched to fidaxomicin for first for new cases, but we are still actually very worried about the cost. We used to have a Vanco first, and then only using fidaxomicin with recurrences. One thing that we've run into, or one thing that sort of may help, is, so people often are saying, oh, the patient's not responding to vancomycin. But one thing that our C. diff experts have actually sort of called out is that diarrhea may not resolve immediately with the Vanco, mostly because there's an inflammatory component that takes a while to get better, and the vanco itself may cause an osmotic diarrhea. So as long as the other symptoms, abdominal pain, white count, fevers, if they're having fevers, are improving, that may be sufficient. You don't need to basically continue treatment until diarrhea resolves. And you may want to just watch as long as they are otherwise stable, to before you diagnose them with recurrent or persistent C. diff. And I'll see if I can identify some of the papers sort of describing that, persistent diarrhea without, other signs, without, true infection, continued infection. Yes. So Matthew, so these are the kinds of things that we're going to try to put together for sort of the Missouri milieu, because I think one of the problems is the Midwest sort of frequency of certain infections is somewhat different than it is on the West Coast or on the East Coast, which, I think that may be part of what you're seeing is, many physicians are either trained in areas where there are more resistant infections, and they may not sort of be understanding that the antibiotic susceptibilities or general patterns of antibiotic susceptibilities are different in say a place like Missouri. Yeah, so that's the goal. But these are great questions, and stay tuned. We'll send them out once we got these things ready. So vanco versus Fidex or C. diff. Great. All right. This has been a great conversation. And happy to hear further suggestions or requests. Just send them to us or raise them at our future meetings. I did especially want to call out some of our partners at the Missouri Department of Health and Senior Services, George Turablitsi, who is our state epidemiologist, Amy Pierce, who is on the call today, who may not be unmuted, but she's been a strong champion for antimicrobial stewardship throughout the state of Missouri. So when you sort of hear our state being lauded as at the forefront of antimicrobial stewardship, that's who to thank. And Corey Lance, who is our new antimicrobial stewardship pharmacist for the state, who will be sort of the lead on many of these things going forwards into the future. So if you have any questions or you want help reaching out to them, you just feel free to ping us. We're happy to connect people. All right. Does anybody have any last thoughts or questions? Otherwise, I'll give people 15 minutes back of their time on this busy Monday, I'm sure. Stay tuned for our next webinar, which will probably be in probably around February or March. I hope everybody. Oh,
I was just going to say, please use that email. We had a lot of good communication using that email last time. And so we really look forward to hearing feedback from you guys and questions and things that you want to hear about. So please use that email.
Yeah. Oh, also, if anybody has people they know who weren't invited and should have been, please just forward their emails over, and then we'll send them the invite so that they can get on all the emails. We're going to be working on like sort of mass delivery and sort of invites, but that's a longer and more complicated process. So we're happy to reach out individually to anybody who could benefit. I hope everybody has a happy holidays. I hope it is a nice and quiet holiday season this year. Thanks everybody for attending, and we will see you next time. Please stay in contact. All right. Take care, everybody.